the So Why podcast with Step Care Solutions. So why are we excited about Step Care 2.0? SC 2.0 is an innovative and transformative model for mental health and substance use healthcare that leverages collaborative efforts and technology to transform systems for better access and outcomes. And SCS exists to help organizations and communities reframe, rethink, and redesign the delivery of mental health services through flexible, open access, recovery-focused approaches. On this podcast, we explore issues and challenges, as well as ideas and solutions around how to create person-centric systems that are holistic, accommodating, and thoughtful. My name is Shauna Cronin, Vice President, Strategic Partnerships and Communications at Step Care Solutions, and I will be your host for this episode. As part of our new podcast season, I am hosting conversations with leaders and experts at national organizations focused on rethinking Canada's mental health and substance use health systems. Thanks for joining me. My guest on this episode is Michael Cooper, Vice President of Data and Partnerships at Mental Health Research Canada. Michael is an experienced charity executive with over 16 years of experience in fund development, project management, and government relations. Michael advocates for improving our understanding in detecting, treating, and managing mental health issues. He has a strong focus on the utilization of data to inform policy and advance mental health care in Canada. He currently oversees MHRC's large-scale data project tracking ongoing mental health of Canadians. Mental Health Research Canada is a non-governmental registered national charity committed to making mental health research truly count for Canadians. With 1 in 4 Canadians impacted by mental health challenges, the gap between what people need and what's accessible continues to grow. MHRC bridges this gap through population data collection, analysis, and rapid reporting, studentships and fellowships, supporting and leading innovative solutions, partnering with like-minded organizations to address real-world, current mental health needs. I'm excited to share my discussion with Michael about how to mobilize evidence to transform mental health systems by shifting from a model where research findings are not simply published in journals, but where they are a central, dynamic part of the system design process itself. Okay, Michael, thank you for joining me today. We're going to talk about the research to action gap as a start.
Okay.
And you and I have both worked in this space for a while. This is something that isn't new necessarily to the sector, but I'm really curious from your perspective how we might be able to move through and what is the research to action gap. So we know that traditionally it's been slow for us to translate mental health research into practical change. I'm really curious about what you think are the biggest barriers to preventing evidence from being effectively applied in real world times.
That is a big question, and certainly something I'm happy to sink my teeth into. There is a paper that a lot of people point to which says there's a 17-year gap between research to action, and it's based on health data, not necessarily mental health data, but health data as a whole. I think there's a number of reasons. One, we've struggled in the mental health sector to have really good quality data. We've specifically not been able to really measure inputs and outputs. And if you can't measure your inputs effectively, it's really hard to actually validate your outputs. What impact did this program have if I don't really have a great evaluation tool on the input and then you have a great evaluation on the output? That's the first sort of challenge I think that exists is we've really far too existed in this space of fuzzy data. And, if I break my leg, you can tell whether or not I'm healed, whether or not I can walk around on my leg or anything like that. But sometimes with anxiety, depression, a lot of these really common mental health conditions, it's not just about trying to cure it. What you're trying to do is treat it. And a lot of these are lifetime challenges. So the end goals are really different for a lot of these. So I'm going to start by putting that all under the umbrella of data and how data is different in mental health compared to physical. The second thing is we have a lot of different individuals inside of this sector. You have clinicians, you have, family doctors and specialists and, the sort of regulated industries that we have that support a lot of people in mental health. And then secondary to that, you also have peer support. You have unregulated industries at the same time, which are valid and helpful. We don't have enough service providers, so it will take all of these to address these sorts of challenges. So we don't just have like a doctor that treats your broken leg. We have 7 or 8 different types of practitioners that you may get involved in, all of which have their different regulatory bodies, all of which would approach this from a different perspective. And frankly, one of the challenges we've seen is that if you want to produce evidence of, say, a psychiatrist intervention, family doctors may not want to look at that. They want something from their own space. So that's the second bucket I would put into the challenge of why we don't are not really good. And I think the third piece that I would put underneath this real challenge is just inertia. We've never really been challenged, and because we don't have great data, it's really hard to hold people accountable for not implementing those sorts of changes. And people will always inherently want to go back to the things that work. We used to have this saying that, the worst thing you can say is, why is something happening this way? And you say it's just because it's always happened that way. And if you can't answer that question in an intelligent way, my general philosophy is everything should be reevaluated in terms of how we do things. And a lot of people, though, they're very comfortable with how they want to do things, and it does take a significant push to move them into something new.
Amazing. And I love how you touched on so many different facets there. It's not really just a research to action straight line or linear process. It's really complex and integrated into the system design work that we're all trying to do. And you spoke a little bit about knowledge translation there, trying to make sure that the context is appropriate for the people who might pick that up and see themselves in that research. You also spoke to the system design component. So I really want to pick that up. And it's linked to data and outcomes, because I love how you created that connection for us there, that it's not a linear process, it's a cyclical process where good data, good evaluation can actually inform research to practice models and implementation processes. So how do we make all of this a dynamic part of system design itself? How do we really create that integrated approach and think about it all systemically for change?
Well, I think one of the things that I've tried to do with our work would be to start with a very bird's eye view of mental health. We've historically come at it from piecemeal. Like, we've got data that comes through the public healthcare systems to CAI, and gets rounded up on a national level. It's inconsistent province to province. There really isn't one way to submit data, billing codes, et cetera, et cetera. The insurance data is another piece of the work. So we've never really had a really good holistic view of how people access supports in this country. We know that community players are a massive piece. One of the things that's been identified is, for example, in a lot of places, you can't go to your doctor that many times for a mental health challenge. You might be limited in how many times you can go see your family doctor for that. You might be limited in terms of how many times you can go see your group insurance provider funded specialist. And so a lot of people end up in the community care side when they're looking at a sustainable long-term solution. We've really never collected data on those sorts of spaces. So my counter to that was we needed to start from the other end of it, which is asking people how they're accessing services. And then once we have a really good landscape of how people are accessing services, we can start building now we've got the whole puzzle. We know what the whole thing should look like at the end. Now we can start figuring out, well, this puzzle piece and this puzzle piece, these are kind of how they all fit in together. And the one thing that I think people aren't really crazy about when I say this, but sometimes perfection should not be the goal. We should be looking, even if the puzzle is a little bit fuzzy, and even if it's not as precise as, because I said inputs and outputs can be challenging, especially for so many people who have so many challenges that might be intersecting. I'm not looking for perfection. And what I think we need to do is we need to look at a body of evidence and all this information, even if sometimes it's a little bit fuzzy, and we have to be willing to accept that. And I think the other half of this as well is, as I mentioned, there's so many different types of providers. We have to be prepared to collaborate across different groups. And we need to be able to communicate in a way that's consistent, because I know that there are several groups within this that may not value the other side's efforts in mental health. And I think that's a problem. I think we do need all to work together towards one consistent piece. And it's been also a challenge in an area that's been traditionally underfunded, that instead of collaborating, we tend to want to compete. And that's sort of one of the core reasons that this exists.
I love that. And it aligns so strongly in some of the work that I do in relation to large scale system transformation, where partnership is really key and critical. And we
Yep.
won't see that systemic transformation if we're not partnering together and sort of moving to understand the system in different kinds of ways. And I love your metaphor of a puzzle, or your analogy of a puzzle. And I wanna sort of dig into that a little bit more and talk about, you talked about different perspectives and trying to interpret evidence. What if we back that up a little bit and we think
Sure.
about, what do we even consider evidence?
Yep.
And could you talk, I know you folks do a lot of work at MHRC trying to
Yep.
really integrate diverse forms of evidence and
Yep.
knowledge and ways of knowing. So can you talk a little bit about what that means, how that looks, and how do we integrate and try to build understanding about different forms of evidence, and specifically the nuance of lived expertise in informing research and data and implementation?
I think all of your questions are excellent, and thank you for your kind comment about our work. How do we look at different forms of evidence? I think that the first thing that the general public probably doesn't understand is that when it comes to mental health, you're often not curing, you're treating. So I think, if you're looking for evidence that's a cure, we tend to look for things that are more pharmaceutically driven. We look at things like, when we're talking about treatments, we're also talking about, there are, you know, progress in CBTs, cognitive behavioral therapies, and so on and so forth. What I look like when I'm looking for evidence is there a sustained improvement over a period of time? Because we do know that mental health is a combination of genetics and your predispositions to certain mental health challenges, and then environmental factors. So the functional question that we would be looking for when we're looking at treatment is, are you satisfied with your care over an extended period of time? Is it meeting your needs? Do you feel like it's meeting your needs? And these are really simple things that I think we ask individuals who are getting treatments. And the good news is, the most positive people about treatments are the people who are getting treatments. So the perspectives on the mental health sector are actually worse for people who have no familiarity with the sector versus the people who are inside of it. And when you talk to those people who are inside of it and you look at the variety of care, you do see that most forms of care on the whole are actually meeting people's needs and are actually quite supportive. And I think that's the best way we can look at this, which is, instead of actually saying, complex, like this person's had a 17% increase, which is hard. Again, poor inputs, poor outputs. But do they feel it's meeting their needs? Are they able to function on an everyday basis? You can get it at one period and someone could be having a good day, and then you can get it the next day and someone's having a bad day. Mm-hmm. And they might actually respond quite differently to a series of things that are highly subjective in terms of, how am I feeling today? Is my anxiety struggling? These are environmental things that change day to day. So you do need a long pathway of data, which is one of the reasons we wanted to aggregate data over such a long period of time, is we wanted to say, okay, well, we're going to collect data over 3 years worth of 3 years worth of time. And we can actually look at whether or not different forms of treatment are actually meeting people's needs over a long period of time, because you have to do it in the aggregate, because you get a lot of little noise when you're looking at those small little pieces. I actually think that's a big problem in this space, where a lot of people will say, well, I tried this and it worked. And you're like, well, that's great, but it doesn't necessarily work for everybody. You need aggregate data in order to identify the overall trends. And what we really need to also do is identify the specific factors that made it effective for people. So it's not just saying, I use CBT, it worked. What were the pieces of CBT that worked for you? And then what were the things in your past or your experience that made you more likely to actually be CBT to work for you, for example?
Michael, I want to ask you a hard question.
Okay, well, that's for easy. Okay,
and a conundrum, I think.
Okay,
for our
conundrums, sure.
Yeah, a conundrum for our sector, which is, I hear you talking about the importance of longitudinal aggregate data to help us make really informed decisions and accountable decisions, which I think is very important in our sector. MHRC also has a commitment to rapid reporting. And as we talk about trying to produce timely results, that ability to turn some of this around quickly so that we can really create meaningful change now is a pressure point. It's a funding pressure point, and it's an investment pressure point. It's a partnership pressure point. How do you reconcile these two aspects?
It's a good question, and I don't think it's a conundrum for me. So the vast majority of the data that we collect, we've been collecting 70% of the data sets that we collect over a long period of time. So on the things that matter the most in terms of demographic factors intersecting with mental health issues, we have a lot of data that we can look at over long periods of time. We have unique IDs for these individuals. So although we couldn't identify them as Bob Smith, we do know that we can identify people over a long period of time. And there's really two facets to our work. One is the work that we do to generate attention for mental health, to talk about emerging trends, and that's a lot of what the public sees. But what's happening a lot behind the scenes is a lot of conversations about what we're finding in terms of trends through the longer term data that we're actually able to do. So I think your point's fair in terms of the way we're turning things around in real time for a lot of topical areas. But what people don't see is the pieces that happen afterwards, where we collect it for another 3 or 4 collections, another year worth of data that validates that initial finding, and or those long-term trends that we've been tracking for years and years and years and years, which may not be like the sort of thing that no one's going to pay attention to if I say, young people have worse mental health indicators, because we've been talking about it for years. We see it in the data over and over and over and over again, that sometimes people don't want to pay attention to those things, but that's where that longitudinal data really matters.
I love that. It's a bit of a scaffolding approach, it sounds like.
Yeah.
And that really resonates with me on a lot of fronts, because I think another piece that we need to try to think about in terms of a scaffolding way is also how are we building in succession, planning and thinking, and long-term expertise, leadership, impact in our sector. So I want to switch gears a little bit and ask you about your commitment and MHRC's commitment to early career researchers.
Okay.
So first, I might ask you to explain that a little bit, just in case folks listening might not know what distinguishes early career researchers from more established researchers. So if you could just give us a little bit of context about what that means, and what that means for MHRC, that would be great. And maybe we could start there.
Sure. So to be clear, I oversee all the data work. So I don't oversee the early career researcher side of the organization. My colleague Barani does a fantastic job managing that, but I can speak to it in general terms, no problem. So one of the things that MHRC was actually founded on the bones of an Ontario Mental Health Research Foundation, which did fund studentships going back for quite some time. And one of the things that we identified was, while there were some scholarships that existed for mental health, there weren't a lot of exclusive scholarships that existed for mental health. And the other thing that was identified when we were doing some of our early strategy work 6, 7, 8 years ago, would have been that we don't see enough researchers who are collaborating with the community. So the idea was sort of hatched that we would do mental health studentships primarily for students who are getting their masters. We also do PhDs, and we do college, and we also do some undergrads as well too. And the idea would be that they have to do typically some sort of a practical research project as part of their academia work. So we partnered with often with MyTax, which funds half of that studentship, and we'll fund a student who will get about $15,000 typically is the amount, which will allow them to both support them as a student, essentially like a scholarship, but also it supports them to do a research project in the community tied to both academia and a community-based partner. So that allows them to implement a solution, for example, and monitor its impact in the community as well too. That's essentially how we've structured a lot of these studentships. And it's been really excellent for us. I've taken in several students to support us on the data work side of things. We've had Indigenous students, which have been really important for us to highlight that. We've now got a studentship in every province and territory that we've done across this country as well too, which has been really important for us as well as to impact everywhere across Canada. And again, it's always tied to a research project that is implemented during typically your master's. Sometimes it's a fellowship for PhD, but typically master's, and it's part of that research project you have to do in order to pass your program, essentially.
Yeah, I love hearing about that sort of commitment to community or practice-based research and really trying to move that forward. And I think from an implementation and system change perspective, we know that when we also embed in research and knowledge gathering more of that knowledge to practice right from the outset and that community
100%.
component to the work, we see that impact a little bit on that 17-year gap that you initially spoke to. One final question on that front, is there a way that early career researchers can get involved, or what is the process for them to reach out or to understand more about this program?
Yeah, so I think the simplest thing to do is to get onto our mailing list, because we do a number of calls through the year for studentships. It typically involves, like sometimes a funding partner will come in and say, we want to fund X number of students in workplace mental health. Or a province will come in and say, we're going to co-fund or support the studentship in Saskatchewan or Ontario or whatever. So the simplest way to be involved is simply go to our website, www.mhrc.ca, sign up for our newsletter, and all of our both all the data work that I lead, but also all the studentships are actually promoted through email blasts that come to individuals on our newsletter. It's probably easier. You can check our website all the time. And there are certain ones that happen every year, like we've been doing an Indigenous studentship right before Truth and Reconciliation Day at the end of September. We just passed that now. But some of the other ones are inconsistent in their timing. So the best thing to do is to get on that mailing list.
Awesome. And thank you for your organizational commitment to truth and reconciliation, an important piece for all of us working in system transformation to be accountable to. So Michael, I only have a couple more questions for you, but I really want to get a sense from you about what makes you excited about the future. We all do this work because we want to see good transformation and good change. You work in the area of research. You have already outlined for us today so many interesting aspects and components of research that's happening across the country. But if you had to pick one area of research you believe has the most potential to fundamentally transform our mental health system and mental health care in Canada,
Yes.
let's give it the next 5 years, maybe 10 years, because we know what implementation looks like. What would you say it would be and why?
So the space of, well, I think there's two things that we're making progress on and we need to make progress on. One is data. And I know we started this conversation with data, but I started at MHRC in 2019. By 2020, we had identified that there was a lack of real-time data in mental health that was looking at that big puzzle piece, that the overarching view of how people were consuming mental health services and what their needs were across the country. And since we started that, there has been a massive movement towards more data in mental health. We've got centers of excellence set up. Every province is now doing more in terms of collecting data around mental health. And every province is also looking not just in terms of the data we're collecting from clinicians, but the provinces are making progress in terms of working with the community partners that are funded through the provinces to actually get better data. So we have seen significant change in this data space. And when things like Wellness Together Canada existed, they were making tremendous strides in terms of collecting good data. And this is new. I don't want to pretend that we're not making progress on this. And I don't want to pretend don't have a while to go on this, but there is a shift that's currently happening. And I just wanted to say that when I started doing this data work 5.5 years ago, there has been a significant move, and that makes me excited. The second thing I think that needs to change significantly in this country is how we understand mental health. I have consistently said that there is a literacy gap pertaining to mental health in this country. And functionally, that is manifesting in a whole host of different ways. We know people are consuming, especially in the youngest generations, a lot of content around mental health. They're hearing it from their celebrities. They're seeing pieces on their TikTok. I'm not on TikTok, but I assume it's there. And when we actually look at the consumption of mental health content, it's dramatically higher, but literacy isn't going up with it. So people are getting a lot of content, but it's very much, it's very much raw. You need to understand, mental health is an important issue. And I talk to Bell Let's Talk about this all the time, where they're like, we really wanted to address stigma. And we have done a lot of progress in terms of addressing stigma, but that needs to manifest now into increased awareness of our mental health and being able to actually understand things around our mental health, from understanding the difference between a bad day and a clinical diagnosable condition. I don't think most people would actually have some context for that. And it's not just that, they're biased because they're trying to gauge their own experiences. It's they just don't understand the differences between those terminologies as well, too. So I think we have a long way to go in terms of literacy. I think we've also continued to find a delta between how I feel about you talking to me about your mental health or me talking to you about my own mental health. There's a delta between self and externalizing stigma. So I think we have some progress to make on there as well too. And that's one area where I think we've made some progress, but I think we have a long way to go on that as well. So those would be the two areas that I'm hopeful for, because I've seen progress on both of these. I've seen great programs that are coming around literacy in different provinces. We don't have one gigantic national one that's, taking the whole country by storm. But I've seen pockets of great literacy work being done. I see great things in terms of removing the first layer of stigma, which is my comfort in hearing about mental health. And I think we have more to go on that, but I think we're making progress, and I'm excited for that.
Thanks so much, Michael. And I would definitely agree. I think, since sort of the inception of Out of the Shadows, like as a country, we've come so far in trying to talk about stigma and discrimination and better understand it. And I think there's a lot to leverage now in terms of what we've done across the country. To your point, it's a continuous journey and it's a continuous conversation, and there's more work to be done. So it's important to be diligent about that conversation.
Who have better stigma and better literacy are better equipped to handle themselves to address that. It reduces the need on that. It addresses the people who may not need help but are seeking out and clogging up the system. I don't think there's a massive amount of that, but I don't want there to be any. We have to maximize the system that we have. So to me, it crosses both from a preventative standpoint, but also a service delivery standpoint, when we started talking about these sorts of issues and maximizing the limited resources we have in an overburdened system.
Absolutely. So we've come to the end of our time together, but I want to ask you, is there anything else you want to share with our listeners that we haven't covered that you think is important, something to leave them with? Any final thoughts?
I'm really also thinking a lot about digital mental health these days. I've found a lot of great research that indicates that Canadians are not really embracing a lot of digital mental health solutions. There's some data that indicates that Canadians are incredibly protective around their mental health data. And also they're very sensitive around how they get treated. So we've been talking a lot about hybrid type solutions as being an effective way to maximize digital technologies, as well as artificial intelligence, along with a real person on the other side of that. So we've been looking a lot at that issue recently, and I see a lot of really interesting things coming down the pipeline. I've been monitoring recently the, in addition to digital and AI, problematic gambling and the impact that problematic gambling is going to have on our mental health across the country as well, too. That's been another big area of exploration. And I've been doing a lot of gendered work as well too, trying to understand the unique needs of women versus men. We just recently released a women's mental health report. We're going to move into Movember and work with a number of those partners in terms of looking at men's mental health and the unique cultural differences that we've established between these gender norms and how we access mental health. I think it'll be something that I'm sort of interested in looking at going forward. There's a lot of areas that I feel like we need to increase our understanding, and I'm just really focused on trying to bring novel research to the fore so people can understand this better.
I think those are such important topics that you've added there, Michael, and it makes me think as well that like linking them all together, we had the conversation about stigma and how there's still work to be done. And especially when we look at what's happening digitally right now and the use of AI, and then we look at some of that gendered mental health need, that piece of stigma is still there and strong and influencing a lot about how things are manifesting in the digital space for Canadians and for beyond Canada as well. So those are really important topics, and I'm glad to hear you folks are giving it some thought. Thanks again to our guest today, Michael Cooper, the Vice President of Data and Partnerships at Mental Health Research Canada. For more on the work of Mental Health Research Canada and other key items for discussion from this episode, please find links in our show notes. I'm Shauna Cronin, Vice President, Strategic Partnerships and Communications at Step Care Solutions. Thank you for joining us on this episode of the So Why podcast.